So a huge warm welcome to everybody for joining this session today. So it's a Build Back Better consultation that is going to look at maintaining routine immunization in the era of COVID-19 vaccination and give us a real view from the front line. So next slide. So I'm Laura Nic Lochlainn, and I work at the immunization department in WHO headquarters in Geneva. And within my role, I'm the focal point for a number of areas, but I think specifically of interest for this topic today, I work on integration, life course vaccination, missed opportunities for vaccination, and home-based records. And as part of my work, I really aim to promote the importance of these focal point areas in terms of strengthening primary health care and also their links to universal health coverage. So next slide. So the objectives of today's session are to share some of the key learnings on what worked in the efforts amongst health workers to restore and maintain immunization services that were disrupted by the COVID-19 pandemic. It's been a very challenging 2 years, so I think many of us will have some lessons learned on what worked and what didn't work. And I think the other objective is to identify the strategies that are being adapted by country programs and frontline managers to kind of increase routine immunization as the COVID-19 vaccine has been rolled out. So we also hope that we can produce and disseminate a short digest with some key insights on restoring and maintaining routine immunization in the era of the COVID-19 pandemic and vaccination rollout. And I suppose at the moment, COVID-19, when that end is in sight, is not clear. But I suppose we're going to have to adapt our systems over the coming years to really try and see how we can become and return to a new normal. Okay, next slide. So there's the session background for this is quite dense, but I think what we can learn from, or what we know from since March 2020, which seems like a very long time ago now. We had the COVID-19 pandemic declared, and really in many countries we saw major disruptions happen to systems, immunization systems, and just overall general health services. And I think it's very important that, during these disruptions, we had to adapt how we worked. We had to adapt how we communicated with the people that we generally would interact on a day-to-day basis, and also consider how we can deliver immunization. Then late in 2021, we saw the rollout of the COVID-19, or in early 2021, we saw the rollout of COVID-19 vaccination in some countries. And there are some countries that are more advanced in rollout compared to others. So I think there's definitely opportunities for us to learn from others. And also if countries are facing challenges, what can be done to overcome those, and what can others learn from those challenges also? We also want to think about, there's some really big successes that we're seeing in some countries to the deployment of the COVID-19 vaccination, but also we want to ensure that we don't have this attitude of having this kind of siloed approach. We also want to consider how we can continue to strengthen our routine immunization. So the USAID funded a Momentum Country and Global Leadership Project has worked with WHO on documenting these disruptions and also trying to synthesize some lessons learned from the responses effort. So drawing on the collaboration that has happened with the Geneva Learning Foundation, and for many of us that have been involved in many of the scholar programs and other sessions that have been held by the Geneva Learning Foundation, I think we've been in contact with many of you, and we know some of the great efforts that you put towards to document some of the experience that you've had, and also things that you would like to do to try and implement and improve your programs. We'll feature some of the work that the Foundation's Peer Hub exercise had back in 2020, and our esteemed panel will share the strategies that they used to restore and maintain routine immunization services after we saw the COVID-19 pandemic affecting us in 2020. And we also have some global technical experts in the panel who will highlight the cross learnings from these country experiences. And we will ensure that the conversation concludes with some take-home messages that are going to be designed to, I suppose, energize and inspire those who deliver vaccines to keep the fire burning and to keep working hard to ensure that women and children continue to receive these critical life-saving vaccines, even as the COVID-19 vaccination efforts are being rolled out to target adults and others. So with that, I think it's We're very fortunate to have our special guest here, Dr. Folake Olenka. Dr. Olenka has been at forefront of many of our immunization and other efforts because she has had great experience over the past 25 years in clinical practice and public health, spanning senior technical management and global leadership positions. She's worked in many of the regions around the world, including Africa, Asia, Eastern Mediterranean, and the Caribbean. And in her current role at USAID, she serves as the immunization team lead and as USAID's COVID-19 vaccine access delivery initiative lead technical advisor. She is currently the chair of the IA 2030, and that, for all of you who are, I'm sure, are very familiar with that, but that's Immunization Agenda 2030, which is a strategy for immunization for the next decade. So she's the chair of the IA 2030 Strategic Priority Area 1 Working Group for immunization programs for primary healthcare and universal health coverage. So a very warm welcome to Folake to the session today. We're very fortunate to have you here. Then on to the next, we have the next slide. We have our fantastic moderator, Dr. Chizoba Wonodi, with us today. So Chizoba is also an esteemed public health expert who has many years' experience, and she comes from the Johns Hopkins Bloomberg School of Public Health and also the Nigeria country director at the school's International Vaccine Access Center. She also serves as the director for the immunization. She also serves as the director for the immunization for the 5-year USAID funded Momentum Country and Global Leadership Project. And she has been a public health physician with a great interest in vaccine research policies and programs, and with the aim to improve immunization access, coverage, and equity within integrated healthcare systems. So a huge welcome to Chizoba. Then on the next slide, we have the beginning of our peer lab, Geneva Learning Foundation Peer Hub alumni. So the first is Dr. Abdurrauf Tahir. So warm welcome to Dr. Tahir, who is joining us today from WHO Pakistan. So he is a graduate from Pakistan and holds an MPH from the same institution, and he's been involved in immunization and preventive public health activities and currently serves as a WHO officer in Pakistan. Our next Geneva Learning Foundation Peer Hub alumni is Bernardo Badiaco, and he is from Ghana, and he has a certificate in logistics and supply chain management from the University of Ghana and a master's degree in public health. So he has worked for 3 years as a supported supervisor in logistics management for Deliver USAID. And for the past 6 years, he's been a district director for health services, first for Bosom Tui district and now Amasi West districts in Ghana. So huge warm welcome. Then our next panelist is a global expert. This is Lubna Hashmat, and she holds a master's degree in development administration from the Australian National University and also a master's in anthropology from the Quaid-e-Azam University, Islamabad in Pakistan. So she has worked extensively on improving maternal child health and immunization coverage in Pakistan through designing and managing context-specific programs. And in 2015, she received the Excellence Award from the Australian government in recognition of her contributions to community development and governance in Pakistan and beyond. And on to our final global expert panelist, Dr. Muyana. He's the executive director of the Abuja-based Solina Center for International Development and Research. And this is an organization which works on health systems consultation and implementation. Dr. Aina leads SCIADAR's work across several African countries, including a significant portfolio centered on strengthening systems for routine immunization, polio outbreak response. So a huge warm welcome to all our panelists. I think it's a really excellent opportunity for us to really learn from each other. And there's a warm breadth of experience amongst everybody here today to really have a great opportunity to discuss and share our experiences. So warm welcome to everybody.
Thank you so much,
and now
Laura.
I pass over to, okay.
Yes, please go ahead.
I'm going to pass over to Folake for her welcome, for her goodwill message.
Thank you very much, Laura, for the warm welcome. And I am excited to be here today. Just to share a few thoughts as this session gets underway. It is a pleasure to join you in this event together to learn, examine the issues of disruptions from the COVID pandemic and identify strategies to build back better. Routine immunization and broader primary health care. COVID-19 has dented immunization efforts globally. And the data from the recent WNIC estimates show that 22.7 million children missed out vaccinations in 2020. That is 3.7 million more than those who missed vaccinations in 2019. So the impact to childhood vaccination efforts has been uneven. And we can see that the Southeast Asia, Eastern Mediterranean region suffered greater setbacks to childhood vaccination efforts from the COVID-19 pandemic compared to other regions like Africa, the Americas, and Europe. We can also say that the efforts for recovery has also been a major priority and really resulted in balancing out the effect in some of these regions. And so we have an estimated 17 million children who have been ascertained to be zero dose, and that is those who have not received the first dose of DTP, who are predominantly reside in the African region and in countries affected predominantly by conflict. We've also seen that the measles vaccination coverage has declined to 84%, which has resulted in 3 million more children being unvaccinated against measles, putting them at greater risk of infection. And we know that this is a disease that is highly infectious and epidemic prone. So this really gives us cause for great concern. We also have not had the level of coverage we would expect to see in terms of the HPV vaccine, which is predominantly targeting adolescents to protect them against cervical cancer. And so for the first time ever, we have seen a decline of the global HPV vaccine in 2020. A major reason for these reductions in coverage is the disruption in service delivery, particularly outreaches for vaccination, as well as facility-based services, which were largely affected by the initial lockdowns, movement restrictions, and continuing strain on health systems and human resources in countries. So a number of studies have documented the recovery efforts as well as the catch-up, particularly in the last half of 2020. And there have been some encouraging examples, case studies to learn from and adapt as we work to bring back more children on immunization schedules, reach the missed children, and ensure that countries that are lagging behind were able to rapidly close those immunity gaps. You will hear much more about that today in the discourse that would take place subsequently. So it's been about 2 years since the pandemic was declared and the immunization systems disruptions, as well as other primary healthcare essential services disruptions. And so we're looking at a cohort of those who have missed their vaccination that are about 2 years of age now. And they're slowly and gradually aging out of the country's immunization schedules, which often targets children less than 2 years, 1 to 2 years. So policy changes and acceleration of catch-up vaccination will be needed to ensure that these children do not continue to fall through the cracks, and over time, build a large subpopulation of accessible individuals. So events like these that you're having today are really, really important to elevate the voices from the front lines and ensure that there is a dialogue so that we're able to surface the learnings, lessons, and experiences that can help to restore immunization programs and build back around the world. So this event is also a forum to advance the Immunization Agenda 2030 agenda of leaving no one behind and ensuring all get to enjoy the benefits of vaccination. So on behalf of USAID and the Momentum Suite, we are delighted and we look forward to the rich exchange today on the issues and actions needed to ensure full recovery of immunization systems, catch up missed children, maintain immunization services, but also look at opportunities to strengthen the system and prepare for the next and future pandemics. So with that, let me hand back over to the moderator and really look forward to this conversation today. Thanks.
Thank you so much, Folake, for that excellent overview. You really set the stage for the conversation that we're about to have. And what I'm gonna do for the rest of the session is I have a series of questions that I'm going to pose to the panelists, one after the other, so that you can give us your perspective from your own front lines. And then after that, we'll open it up for question and answer to the public and to the audience members, and we will wrap up. So I'd like to first go to Pakistan, to Dr. Tahir. You were part of the Peer Hub exercises, and you shared your experience during the Peer Hub. Can you tell us what has been your experience concerning disruptions to routine immunization in your country or in your locality as a result of the COVID pandemic?
Thank you. Greetings from Pakistan. And thanks again for giving me the opportunity to share my experience. Basically, I am related with the WHO as immunization officer and the surveillance officer since last 10 years. Before the COVID-19, I was the districts which I was looking after, basically the routine immunization and essential immunization, the coverage and the other parameters, they were about approximately 86%, 87%, and we were having some challenges with the high-risk migratory mobile population like the nomadic population and the seasonal and the economic migrants and the people who are living in the deserted and the riverine areas, who were continuously basically having the some strategy to cover those children. But after the COVID-19, there was some drop in routine essential immunization process. First of all, basically this was the new thing. And as far as the cultural diversity in our country is concerned, some of the strata they are literate, some class basically they are not well educated. So whatever thing is propagated on the social media, usually the people they do perceive that it is correct. Either it is propagated by some miscreants or some other individuals. So initially when we used to go to the community for the outreach sessions, whenever I went to monitor the outreach sessions, there was drop and the people, they were having some misperceptions in their mind. Actually, during the initial phase when there was the COVID-19 was on rise, there were some deaths from the hospitals, and the people usually they link those drug deaths with the misperception that basically the on-duty doctors and the healthcare professionals might have given some poisonous injections to the patients, and the people they have died. Due to that particular reason, they were not visiting the hospitals and other health facilities. So with this misperception, whenever there was outreach session, lesser number of people they were coming with their kids for the essential immunization processes. So I would like to quote one example. I went to investigate an AFP case in Tahir Tausa. Whole of the community in that particular village, they were on their roofs with their guns that probably you have come to pick our kid and pick our individual with you. Probably he is having some virus and you want to kill him. Then we sat with their community individuals, with the community influentials, and we taught them that it is just the part of surveillance, and the kid is suffering from certain ulcerative paralysis. Only the stool specimens will be collected to see whether the cause of this paralysis is white poliovirus or something else. So, along with the district health management team, along with the local health government officials, we sat and we discussed the scenario how to remove these obstacles, how to remove these misperceptions. So, as a role model healthcare professionals, what we decided that as far as the first strategy is that we should implement in true letter and spirit the infection prevention control program, the modus operandi. So, at the entrance, we used to distribute masks, and we used to give the hand sanitizers to some individuals. After that particular process, they used to come and we used to give routine EPI injectables. So with the passage of time, with adherence to the infection prevention control program and other parameters, we were able to convince the community that we are here for your kids. And in some instances, we showed them the videos, and we brought our kids that basically the kids of our healthcare professionals who were basically due for some routine injections. They look at these kids. These are our kids. We are giving these injections to our kids. So with the some innovations and other steps like infection prevention control program and other programs, were able to boost up the routine immunization program. But this process lasted for 4 to 5 months.
Right. That's interesting. So you're saying that the COVID pandemic actually increased hesitancy and suspicion about vaccination as a whole, and one thing you did to overcome that, should I say, hesitancy, is to provide for the community mask and IPC training. So that's a good innovation, so to speak, or incentive for immunization. I want to now go to Mr. Bernard. You also had some case studies that were submitted to the Peer Hub, where you described some interventions that were put in place to address the disruptions in your community. Can you tell us what some of those innovations that were developed to combat these disruptions to routine immunization in your community in Ghana?
Yes, thank you very much. And it's an honor and a privilege to be part of this August panel. Yes, in 2020, when we experienced the outbreak of the COVID-19, we had a population of about 85,497, with under 5 years population being 14,108. We all know that disruption of immunization services can lead to increased numbers of susceptible individuals and increased likelihood of vaccine-preventable diseases, such as measles, and may result in increased morbidity and mortality. So as the district health director, I had to mobilize my team and vaccinators to be sure that we maintain and sustain the EPI program in our district. So these were some of the things that we did. We lobbied for personal protective equipment from stakeholders, example, the district assembly, from our rural banks, NGOs, mining companies, and also we had support from our regional health directorate in terms of PPEs and hand sanitizers. Now, we realized that some of our staff were quite apprehensive and hesitant to go on outreaches and even organize static sessions because of the COVID-19. So what did we do? We had to encourage them and motivate them by supplying them with the hand sanitizers and face masks, as well as face shields. And as a means of leadership by example, I joined them during the vaccination sessions as a way of motivation and encouragement. And then also we took advantage of the public address system on our district pickup, local community information centers, meetings with chiefs and queen mothers and opinion leaders to sensitize them and educate the populace and assure them of their safety in order for them to be able to come out with their children for vaccination sessions. Again, we also encourage all mothers and caregivers that they should have their mask on and then also come with hand sanitizers. Even when they forget it, we already have hand sanitizers also available for them. Again, we increased frequency of static CWCs. So previously it was 1 static day. Now we increased it to 2 and 3 days. And then also we reduced the number of mothers who are coming with children to a maximum of 25 per session. Then we also increased our outreach points from 68 to 74. And then when it came to home visiting, our community health nurses are supposed to go on home visiting, but we restricted it to the at-risk population, example, the malnourished children. And then also we made sure that when they come for CWC, they receive the complete package of care at a go. So there was no fragmented services. That would let them keep long and expose them to the infection. So we made sure that everything is as quick as possible, but they get the comprehensive and quality care that they need. Again, as a district, we came up with our own 70% hand sanitizer, which was approved by the Food and Drug Authority. And that was helping us in the area of infection prevention. And then also, we organized a special immunization activity on monovalent OPV. And this helped us to also trace the missed children as a catch-up. Now, we also had issues we had a Muslim community where they were very, very hesitant to receive vaccination at that time. So what we did was to involve an Islamic cleric, an opinion leader, and some of our community health nurses are also Muslims. So we all went to that community and engaged them, especially the fathers, for them to understand and appreciate the need for the children to be vaccinated. And this helped us to increase our coverage, especially in that area. And then also we made sure that all our service data is also entered into the DIMS, and there was monthly data validation. So all this together helped us. And we realized that within that period, if you look at a 3-year trend of our performance, we realized that we were able to achieve over 100% coverage, especially for Penta-3. Using Penta-3 as proxy for our EPI, we realized that we were able to achieve over 100%. In fact, we had 122% for Penta-3. I believe that these were some of the measures that we put in place that helped us to achieve this kind of coverage for the district.
Yeah, I think that's so impressive, Bernard. You really addressed the core challenge that both your health workers, both your vaccinators and the community were facing. It seemed like there was a lot of fear, as most of us, experienced when COVID hit. So by, going with PPEs, hand sanitizers, to first of all show that you are providing services in a safe manner, and then also even I liked the idea that you came up with your own hand sanitizer, like you innovated.
Yes, I'll show some pictures as we go along.
Yeah, that's really impressive, and we can see it in the results that you've mentioned. So really kudos to you on that on the work that you guys did in Ghana. So I'm going to move on now to Dr. Lubna. And going back to Pakistan, Lubna, can you tell us right now what you're seeing on ground with regards to the impact of COVID-19 vaccine rollout on routine immunization? We've been talking previously on the impact of COVID pandemic itself, the outbreak. How did it affect routine immunization? But now there's a push for COVID vaccine, which is a good thing. How is it affecting routine immunization?
Yeah, sure. Thank you so much for the opportunity. It is very important to analyze that what we have done from the last 2 years.
You're on mute. You've gone on mute, Lubna. Okay.
Is it?
Okay, we can hear you now.
Okay, sure. Thank you so much. So what I was sharing, that previously the last 2 years has been experimentation, and it is extremely important for us to look back and analyze that what has gone well and what was our failure. I shared a diagram via email where I showed the key elements through a balance. And we see that there were 4 key elements which were emphasized for the deployment of COVID-19 vaccine. Number 1, instantly there was high political commitment with high coverage targets for COVID-19 vaccine without realizing that we have a full-fledged system available or not. And what is the trade-off? Are we going to compromise on the childhood immunization at the cost of COVID-19 vaccine? And nobody compared the overall health economy burden in the long term. So the political commitment was to show high coverage to the world for COVID-19 vaccine without having any thought about compromising on the childhood immunization. So we have had high coverage rates. So till to date, until March 2nd, 228 million doses have been administered, while the total population of the country is 209 million. So if we see 2 doses, around 48% of the population is fully vaccinated for COVID-19. But if we compare these results with the childhood immunization coverage rates, we see 3 major items. 1, high backsliding. Number 2, number of 0-dose children have increased. Number 3, the percentage of dropout children has doubled, which we had previous to the COVID-19. One of the major issues we see that after COVID-19 pandemic, the third-party coverage surveys for childhood immunization have been stopped, and there is a heavy reliance on admin data. And that admin data was analyzed very frequently by WHO for the quality. And there is a serious concern, even if I attended the December Gavi Program and Policy Committee meeting, it was reported that globally, the quality of data has deteriorated. So with those 2 factors in mind, that whatever progress we are reporting at the global level for recovery and building back better is based on admin data. Number 2, if the quality of admin data have deteriorated, and if we are seeing frequent outbreaks, especially for polio during last 2 weeks in African region for this polio-derived vaccine virus, it is reflecting that what is happening, what are we compromising on. So these similar examples we are experiencing in Pakistan too, that we have serious issues for childhood immunization at the cost of COVID-19 vaccine. Over. Thank you.
Thank you so much, Lubna. Those are quite insightful comments that you made. One is that there was strong political will to introduce the vaccine, but not commensurate analysis to look at the economic benefit, the cost benefit of all that effort and financing into COVID vaccination. And then you also touched on the poor quality of data and how that will affect our interpretation of the recovery that we seem to have seen. So thank you so much. And I'll come back to you on that later on. I want to go to Dr. Aina right now. Dr. Aina, I know that you are a private sector guru, so to speak, but still work in the public health space. And from your perspective, how can you've heard that routine immunization is at risk if we don't pay attention to it as we're rolling out the COVID vaccine. And then also the pandemic itself had a dent on routine immunization. How can we do better to strengthen routine immunization during this COVID period? Because you know, we are living in a world of COVID now. So what do we do differently to ensure that routine immunization does not continue to suffer?
Fantastic, thank you. Let me start by sending greetings to everyone, to the moderators, fellow panelists, and colleagues, and the audience. It really is an honor to share this platform with such an impressive group of people and share a few thoughts. I think to address the question that you've asked me, Dr. Chizoba, I will frame my discussions with examples within the context of two of CIDA's ongoing programs. So the first is a multi-year partnership that we're anchoring between the Bill and Melinda Gates Foundation, Aliko Dangote Foundation, and each of 6 very poor performing northern Nigerian states. You know, one of the states, for those who are not as familiar, had Penta-3 coverage rates as low as 2 or 3% at the start of the program. We set up this memoranda of understanding between each of the states and donors, accompanied by basket funding mechanisms, where the donors put in funds and use that to leverage government money to invest in routine immunization and later on for PHC. This worked. It fostered coordination and accountability and improved coverage in these states. And the partnership has expanded in some states to include USAID, to include UNICEF, and the model is even being replicated outside of the country. We are currently anchoring similar programs in Guinea, in Niger, and in Chad. The second program that also serves as context for this is also the flagship FCDO program. FCDO, as many of you will know, is the former DFID. The flagship health program in Nigeria is called LAFIA. And among many other things, one of the priorities of that program is to increase prioritization and funding for healthcare in Nigeria using data and advocacy. One of our specific roles on that is to anchor the COVID-19 support component of the program, which has necessarily made us to look closely at a lot of the things that have been discussed here today. So to the question, yes, a lot of what Lubna and previous speakers have said around the effect that the COVID-19 pandemic has had on routine immunization are very true and very real, and we've seen them, you know, in the context of our work. But I do think that there are a few important opportunities that we can also focus on, and I will again bring examples from some of the work that we've done. To start with, I think we can agree that one of the positive, if you can call it that, effects of the pandemic is the unprecedented level of focus and prioritization and funding that has been pumped into healthcare broadly, but certainly the immunization systems. It would be a shame if we don't leverage this to improve our routine systems. For example, in Nigeria, the massive investment in the COVID-19 response saw very significant improvements in cold chain equipment and ultra cold chain equipment coverage in Nigeria. As of 2019, functional cold chain equipment penetration in the country, we have a World Health System, was at 41% of wards. We're right now more like 79% ward saturation across the country. This jump was in large part due to the Gavi CDS, which is the COVID vaccine funding pool, but it's also being optimized by the CCEOP. Of course, post the pandemic, if we ever do get to that world, this infrastructure will remain, and the number of frontline storage points for routine immunization vaccines has effectively increased. Secondly, the COVID-19 vaccination rollout has been necessarily accompanied by massive social mobilization and demand creation efforts that is far beyond any that we have seen with routine immunization. Now, because in Nigeria, as in many other countries, I would hope, there's been a deliberate push to integrate service delivery. So where you are doing campaigns for COVID vaccine, we should also piggyback on that to deliver routine immunization services. These mobilization resources and other demand generation activities have really also pushed communication and advocacy for routine immunization. And this is really being used to leverage uptake, to drive uptake of routine immunization. Most radio and TV jingles would typically speak of both. Also, as part of the integration, the government launched what is called the SCALE strategy, which really, SCALES is a fancy acronym for Combined Mass COVID-19 Vaccination and Routine Immunization Campaigns, where campaign workers offer both RI and COVID vaccines. And this has definitely increased the reach of routine immunization across all the states where we're working, much more than what was possible before now. Hopefully, this is one of the things that we're hoping that the government will be able to sustain going forward. Another opportunity. Sorry,
go ahead.
Another opportunity is in the data system. I mean,
I was going to ask that question about data.
Yes. Is the data systems. Again, we're all familiar with the administrative data issues. Some of it has been mentioned today, everything from incompleteness to even quality issues. But the government has rolled out something called the Electronic Management of Immunization Data, or EMID system, which is really the first time, frankly, in the public health system that we're looking at patient level data. And the idea is, while this is really targeting COVID vaccination data at this point, it really is to set the stage and serve as a pilot to start to collect and manage patient level data for broader immunization services and ultimately for primary healthcare system. We think this can be transformative to the quality of information that we frankly have for decision making. Also,
excellent.
Yes. If I just have another minute, there's also the opportunity to jumpstart again the transition of the massive infrastructure that was built for polio. Some of that was just left to rot, everything from the national network of fairly advanced emergency operating centers to some 80,000 informal health volunteers. I think what the COVID vaccination drive has done is, again, pushed for us to re-engage these systems and then start to think again about how do you really pull this into the routine immunization system to leverage them. I'm going to pause here in the interest of time.
Yeah. So I do have a follow-on question. I mean, it's really great that the COVID rollout has brought with it massive funding and all these innovations that you've talked about. What do you think will happen when this immediate response slows down? Because most of this funding is coming from external forces. Are the domestic forces matching the need and the level of scale that the COVID rollout is requiring? Are the governments matching donor funding in terms of the rollout?
I will go first, and of course, welcome other panelists to speak from that context. The short answer is no. The governments are not matching this just yet, and that's not a big surprise. However, the opportunity here is that, if we're able to, as is being done, channel a significant part of the resources to building systems, to expanding cold chain infrastructure, that's not going to go. That's going to be there in the facilities to engage community volunteers, better plug them into routine programs, at little or no cost. That's going to exist. To strengthen data systems, that's going to exist. So there are certain things that the money goes into right now, that is going to remain. But there will be there are many things around the infrastructure, around the systems, that if we manage them well, they will be here.
Lubna, do you have a point to make on that?
Yes, 2 points. What I see from Pakistan's context, that we did not rely heavily on external funding. 2 items were utilized which existed at the country level through domestic resource mobilization. One, they deployed army and forces for initial COVID rollout, which existed if we do not have current wars happening and army is not very occupied at the borders. So all those army personnel were deployed for vaccine administration. The second thing, which is the years-long issue of data unreliability, the army introduced very reliable electronic registration system for COVID-19 vaccine. And based on those two very important local resource mobilization and system strengthening, if we are committed politically, and if we have a specific coverage targets, we can deliver on childhood immunization as well. And this has very clearly shown that there is very weak political commitment for childhood immunization. That is the reason that we're still lagging behind with 67% or 72% overall national coverage rates, with more than 2 million zero-dose children and increasing dropouts. Over. Thank you.
Thank you. So it seems like with regards to political will, there is a very high level of political will for COVID vaccine, and we should work to make sure that that translates to COVID political will for childhood vaccination. And through the discussions around integration that Muyi mentioned, we could ride that COVID wave for routine immunization. Okay, thank you so much. I see that there's a comment in the chat where Joyce is commenting that there are scorecards and people are very aware of vaccines and vaccinations now, and that it means that community engagement and advocacy is still going to be key. Joyce, are you able to join and make your comment? So you can request to share your screen and audio. Okay, if Joyce is not going to make their comments, we have just, okay, you don't know. We have just 5 minutes. I can just round up what we've heard here today. Starting from when COVID hit in 2020, we heard from Tahir and from Bernard how routine immunizations were affected negatively. And the biggest challenge at that time was fear of being exposed to COVID, fear of getting COVID. And that affected both healthcare providers as well as parents. And in your own work, you devised some innovations to allay people's fears by providing PPEs, by providing sanitizers, and by changing the way services were delivered so that there were less crowding in the facilities. And then moving on to this era of COVID, we've heard that there is massive political will for COVID vaccination. And we need massive political will, massive funding for COVID vaccination, and great opportunities to leverage what is coming in for COVID vaccination for routine immunization. And some of those opportunities for leveraging are integrating services, strengthening the cold chain system that we've seen reported by Dr. Muyi in Nigeria, even strengthening the data system. For the first time, we're going to have immunization registry, which will help with follow-up. Lubna, you talked about huge dropout rates, and with child level data systems, we can identify kids who have received their first dose, who need to receive their second dose. And that investment in the data infrastructure is something that we can really be proud of and we really need to maintain. And then also, like everybody, because everybody knows about COVID right now, everybody also knows about vaccination. So we can also ride that wave of great public engagement in vaccination. I just want to round up by saying that the immunization global community has come up with the immunization agenda IA 2030, and this is really an opportunity with the massive awareness raising around vaccination for everybody to be involved in immunization and pushing immunization, as that is pretty much a silver bullet that we have for public health to protect the health of the public and then maintain well-being amongst people. I see Joyce is here now. Okay.
Yes.
Okay, well, we have just 2 minutes. Maybe you want to make your point before we close.
Okay, thank you. I just wanted to mention that the way the information, especially of COVID-19, is being shared, it has helped to open up and inform people on the importance of vaccination. And people now talk about those numbers, and they also talk about vaccines and what they do and what they can do. Some people just go for the vaccines just because they have seen the numbers of the deaths of people who are getting vaccinated, and also the successes of other parts of the world. Thank you. They have also come to know many more vaccines other than just the childhood vaccines. Thank you.
Thank you so much. So with that, we've come to the end of the session. This has been a great conversation. I really want to thank everyone, all the panelists, for making our time to share with us. Yes, Bernard. You're on mute. You're on mute. You're muted.
So I've seen a question that has been asked, which I wanted to respond to.
Okay.
Okay, so if you permit me to share a slide. Okay.
Are you able to?
Yes. Okay. So, so the question was about why we're able to have a coverage of over 100%. Yeah. So, with respect to that, it's based on the population that we were given by the Ghana Health Service headquarters and regional, which was an estimated population, because the last time we had a census done was in 2010. So subsequently, we have to estimate the population. But fortunately, we had the census done in this year. So this year, we've been given a new population, and that is giving us a better picture of the population that we have as a district. So as at 2020 until 2021, when we did the population census, we were using estimates. And so as of 2022, we now have the exact population per the population census. So that is why we are having coverages over 100%, which means that the population that we were working with, we had more children than the population that was given to us. So that is why we had over 100% population.
So this 104% was before your census?
Yeah, that was before the census.
Okay, so it's denominator issue you're talking about.
2021. The census was done in 2021.
Okay. Well, I'm glad Ghana has done a census. We are waiting for a census to be done in Nigeria. Okay.
Yes, it was great.
All right. So thank you, everyone. I don't see any other question in the chat. Dr. Iwat, welcome. We are rounding up the session. Okay. So with that, I'd say everyone have a wonderful weekend and stay safe.